So we're ready to start. Good afternoon, ladies and gentlemen, dear colleagues. My name is Philippe Garot from Massy, France, and I'm very happy to co-chair this session with my friend Kentaro Hayashida from Japan. We have a great panel tonight, and I'm sure you know most of the participants in this session. Dr. Buddhari, Dr. Lee, Dr. Min, Dr. Palmerini, Dr. Park, Dr. Tang, and Tsao and Yusuke Watanabe. So the session this afternoon is a live case valve-in-valve and complex TAVR from Toulouse, Clinique Pasteur, France. And I think we're ready to connect with the team there. Can you please... Hello.
Hi, Philippe.
Hi,
Do you
Didier.
see us?
Of course, we can see you.
Okay, cool, nice. So I guess it's good afternoon for you guys. So first of all, it's a great pleasure to broadcast two very interesting cases for the 13th edition of the TCTAP. So it's a great honor for us. Today I will have the great pleasure to work with Bastien de Grelle, who is the rising star, one of our very young partners, as well as Chloé Dulac, Alison Dalman, and Cécile Baller, who's going to help us. So maybe we can kick off the case by showing the case presentation, and then we have a bit of discussion. So here is the team. So today, the patient that we are all going to treat together is a 77-year-old man who is highly symptomatic, very active gentleman. You can see a bit of overweight. He has a past medical history, already a pacemaker, and most importantly, he was treated almost 10 years ago with a dual valve replacement. First, a mosaic in the mitral location, and second, a trifecta in the aortic location, 25. So here is the story today. So the gentleman is symptomatic. The LVEF is preserved, and as you can see, there was a degenerescence of both the mitral bioprosthesis on the stenotic mode as well, and the aortic bioprosthesis as well on the stenotic mode. We are near way below 1 centimeter square, a mean gradient above 40, and a systolic pulmonary arterial pressure that is preserved. Laboratory-wise, a slight decrease in the renal function, and but sinus rhythm. But as I said before, already a pacemaker, and the coronary arteries are normal. So here is we did treat the mosaic in the mitral position. You're going to see that afterwards. But today we're going to tackle the aortic valve degenerescence. As you can see, the inner diameter is not that small, Bastien. It's 22.
22, yeah.
And the LVOT is 25. And so if we scroll up and down within the aortic root complex, we can see that the coronary arteries are quite high. The sinus of Valsalva are really generous, close to 40. The ascending aorta is at 40, so in the range of a self-expanding platform if you want to do that. And if you watch the bottom right part of the screen, Philippe and Kentaro, you can see how bulky, how calcified these leaflets are. And I have to say that both Bastien and we did struggle to cross the valve. The femoral artery, nothing noticeable, a bit of tortuosity and calcification, but very big diameters. So here are the scores, challenging patients, high Euro score, and we decided to go first for a valve-in-valve in the mitral space. So this has been done like 2 months ago, and now he's coming back for the transfemoral aortic valve-in-valve case that we are all going to share together. So Bastien, if we go to the last slide, maybe you can describe the strategy that we have adopted.
Yes, of course. Thank you, Didier. So we already did the puncture ultrasound with right femoral artery. We already preclosure with the prostyle. Then we tried to put the cerebral protection with Sentinel, but the tortuosity was quite difficult. So that's why we didn't do it. And now we're gonna do the SCV 26 millimeter.
Yeah, it's going to be a Evolut FX 26. Maybe we can go live and see the fluoro before we discuss with you guys. So if we watch the fluoroscopy, let me go backwards. So first what you can see, and you're going to Tu peux mettre la fluoro, s'il te plaît, live. On a juste une image fixe de fluoro. Yeah, you only have a fixed image of the fluoroscopy. So, Bastien, okay, maybe we can adjust fluoro. Do you see Kentaro and Philippe the fluoro live or not?
It's not live, but we see Sentinel.
Yeah. So it was quite a challenge for the Sentinel to put the Sentinel. So the team is going to fix that because you need the fluoro to be able to see what we are doing. C'est une image fixe, faut qu'il règle ça tout de suite. Faut qu'on voit l'image live. Tu lui dis de régler ça. And so then we to cross the aortic valve, it was quite a challenge. What Bastien did was to use the Amplatz left one. Didn't work. Then JR5 didn't work, and then at last it was the Amplatz left 2 with a slippery, very hydrophilic wire, a Terimo stiff straight wire. So while the technical crew is fixing the connection issue, maybe you can have a bit of discussion about the patient, Kentaro and Philippe, with Yue. I know that Yue will have to move in like 20 minutes, so maybe we can have a bit of discussion among the panel. Thank you, guys.
Thank you very much, Didier, for the very clear presentation. Very exciting case of the degenerated mitral and aortic valve disease. So could you please tell us why you start from the mitral instead of the aortic for this case? Yes.
Yeah, because it's a very, very important question, Kentaro. And what we did was to assume that the valve that was really, really degenerated was the mitral one. And we did observe a bit of improvement within the symptoms after the treatment of the mitral valve, but the patient was still symptomatic, moving from class 3 to class 2 plus, we would say. And if you remember, the gradient was 14 millimeters of mercury in the mitral, through the mitral bioprosthesis, so it was very, very high.
Okay, great. So because of the time, because you have two cases, could you please proceed to the procedure?
Un peu de fluoro pour voir si on nous voit. Yeah, the thing is that you can't get the fluoroscopy. The technical crew has an issue with the fluoroscopy.
Okay.
Okay. So what are we going to do? I'm going to move. Tu leur dis, je vais aller en salle 5. I'm going to move to the second case. So please have 5 minutes of discussion. I'm going to move to present you the second case, and then I'll come back to complete this case once the technical issue has been solved. So please have a bit of discussion among the panel. I'm coming back.
Okay, perfect. Okay. So Didier demonstrated a very exciting case. So maybe Gilbert. There is some noise. So Gilbert, do you have any comment on this particular case?
I think the question of sequencing is what valve to choose for the aortic position in the context of a mitral valve in valve already. You have to have enough clearance, especially this case, the trifecta is very calcified, you saw. So if you just implant the self-expanding valve and it's underexpanded and you need to post-dilate, will the balloon interact with the sapien valve in the mitral position? I think that's probably, in my mind, the biggest question. Okay, so which would you start from? So my understanding, I usually like to fix the aortic, then go backward. Okay. And also, once you fix the aortic, the mitral, then you can just optimize. And then, of course, we should ask Didier the question, does he plan to fracture the trifecta? Oh, actually, not fracture, but at least remodel to stretch it. Yep. So any comment on this case?
Gilbert, does it make a difference if Didier use a balloon expandable valve rather than a self-expanding valve?
Well, the concern is the balloon interacting with the sapien. It can actually distort the sapien frame. So I've heard anecdotally that can happen, especially when the mitral is very close to the aortic. Sometimes you can see the outflow tract is almost right underneath where the prosthesis is. So if you choose to post-dilate, most of the balloon, 4-centimeter balloon, maybe some of them 4.5. So that can risk, potential interaction. We shall see, but that has been heard before, especially if the pacing is unpredictable.
So the other issue may be, so do you use cerebral protection for all valve-in-valve cases, or you select according to the degeneration of the valve, or you have some other parameters to choose.
Definitely, this is one of the great points to discuss, because in these patients we have a valve-in-valve intervention. The valve has a lot of calcification, and there's a high risk of calcium migration and stroke, of course. And for these patients, who's using, I mean, in routine cerebral embolic protection device? Most of
I would use.
Yeah.
For the case with SPD, right?
Yes, absolutely. And again, we don't have evidence for, I mean, routine procedures to do that. But in this kind of patients with a very high risk of debris and emboli, I think that's meaningful, but we just need some more evidence to do that.
Exactly.
Yeah. So yes, the discussion about the aortic and the mitral devices is really, really interesting. And as you mentioned, one of the, I would say, beauty of the surgery is that you can do both procedure during the same procedure. So do you, some of you have done some combined aortic and mitral procedures, Tullio?
Yes, we have been doing this procedure. In general, we have done this procedure in the same session. So we put the patient on general anesthesia, because it's necessary for the mitral, and at the same time we do the aortic valve. So in general, we prefer to do first the aortic valve and then the mitral valve. Also because aortic valve stenosis is much less tolerated from an hemodynamic point of view than mitral stenosis. And of course, depends on the severity. But our approach is to treat first the aortic valve and then the mitral, for the same reason Gilbert was saying.
So does anyone have any other opinion, different opinion? Maybe Yusuke, do you have any opinion on this case? The sequence of the atrial.
Yeah, I think so. Valsalva is large enough, so I think self-expanding is okay, and also balloon expander valve is still comfortable for use for this case.
For this case.
Yeah.
So it's a trifecta 25. So I mean, if we are concerned about patient prosthesis mismatch, a trifecta 25 would take a sapien 26 or an Evolut 26 or 29. So probably there's not much an issue of patient prosthesis mismatch in a situation like that. So if it had been a smaller valve, I would have definitely go for a self-expanding valve. But if you can put a 26 inside the prosthesis valve, probably it's fine as well.
Yeah.
Any other comments on the complexity of these patients?
And for valve fracture, do you usually do valve fracture, or you actually do the procedure TAVI first and then decide on valve fracture depending on the gradient?
So actually, trifecta you cannot fracture. You cannot fracture,
you
but you can do remodeling,
Yeah.
but you cannot fracture.
But again, I think really interesting discussion to do that before the second valve or after the second valve. It's really something that you can do in both ways.
Donc,
Didier, welcome back.
Okay.
Didier, we can see you.
Sorry guys, yeah, there is a technical issue between here and the meeting there. But let me just present you the second case. Here it seems to work, so we're going to go through the second case, and then we'll see if we can show the outcome of the first case. So today, second very, very challenging case. So you've discussed the valve-in-valve. I heard your discussion, it was very interesting, but we are now in the discussion about a redo TAVI. A TAV-in-TAV. So 87 years old woman who is still very symptomatic and very active, and has a main past medical history. You can see the transfemoral TAVI in 2018 with Evolut R26 at that time. And so LVEF is preserved, a very stenotic TAVI device today that drives the symptoms of the lady. The systolic pulmonary arterial pressure is very high, and so we decided to do something for this patient. Laboratory-wise, you can see the decrease of the renal function. And here is the very important part, and I'm glad to hear that we have such a distinguished panel with a lot of experience in redo procedure. Both Kentaro and Yoe and as well as Yusuke during Tokyo Valves, we could discuss the challenges of a failed TAVR device. We had already a live case, and it was a very intense discussion. So I'm sure we're going to have the same type of discussion. But you can see if you watch the top left part of the screen that the leaflets are extremely calcified of the failed Evolute. And what is quite interesting is the location of the device that is quite deep. Whether it's slept after the procedure or it was left quite down for this lady, that can be kind of lucky for her today because it increases the likelihood, the potential for a redo procedure. So the inner dimension, so you can see that at the level of the annulus and both the leaflets themselves, the cage, the constrained part of the leaflets, we are around 21, 22. So it's in favor of any kind of TAVR device that we could use contemporary-wise. And this is a very important point of discussion, is the coronary risk plane, because you know that there is a risk of sinus sequestration when we go for a TAV in TAV. And here the coronary risk plane is quite favorable because the coronary arteries, due to the fact that the device is quite low in relation to the aortic annulus, the coronary arteries are quite high. And so the coronary risk plane is below the neoskirt, in fact. So it's good. The coronary arteries arise below the neoskirt. So this is favorable. On the femoral artery standpoint, nothing noticeable from the peripheral vessels. Risk score-wise, extremely high, so we decided to do for a redo procedure. No option for surgery for this lady. I'm sure Gilbert is gonna agree with that, and so we decided to go for a redo TAVI or TAV in TAV. So the strategy, right femoral approach, conscious sedation as usual, ultrasound-guided procedure, ACT has to be above 250. That is the case. A single ProGlide preclosure for the right common femoral artery access, cerebral protection device deployment. We're going to pace on the wire, as Bastien is going to do for the valve-in-valve case. And we decided to go with a balloon expandable valve, a 23 S3 here. But we also discussed the potential for Opta Pro 21.5. So everything is open for discussion. So let me show you a couple of fluoro images. Tu peux nous mettre la fluoro. So seeing the fluoro, you can, here is what we have. So you can see that the device is very low. So the bottom, the inflow of the Evolute is not going to be any reference for this lady. So we are really, we have to discuss where we're going to put the device, but something like Note 6, that's what we discussed with Elena and Melody. Here is the equivalent of the free cascoplanar view. Still, you can see the takeoff of the left main, the shadow of the initial leaflets, and most importantly, the depth of the Evolute. So I suspect that it did dive more during the course of the after the index procedure because this was done in 7 years ago, and there's no way it could have been left so deep. So I guess it was pushed down a little bit during the follow-up of the patient. So we did deploy the Sentinel device, and crossing the valve was achieved with a Amplatz left one, as you can see, a straight wire. It wasn't that easy to cross, but not so difficult as well. Despite the calcified aspect of the leaflets, we could cross with the regular combination of Amplatz left one and a straight wire. Now, what I would like you to focus on are the hemodynamics, and then we will have a bit of discussion. And what we see is first a very high peak-to-peak gradient, close to 70, which is huge, 70 to 80. Second, a diastolic aortic pressure that is very low, telling about the amount of regurgitation that we have at baseline. The left ventricular end diastolic pressure is 26. The heart rate is 56. So we have a matrix, our matrix for evaluation of any aortic regurgitation at the end. So please discuss the case. What we are placing the Safari. It's going to be a Safari small that we're going to put.
Okay.
Thank you.
Thank you very much, Didier, for the great presentation. It's really, really nice case, and we have had, and I'm sure my colleagues on the panel have had some delayed left ventricular migration of these self-expanding valve, and which is, I mean, a great point for this patient. It's a key determinant of the procedure, because when we think about redo procedures, we always think about the first valve positioning, and one point that I want to mention, and Didier, the patient didn't have any pacemaker, and despite the deep implantation.
No, that's a very good point. Very good point. No need for a pacemaker despite the depth of the implant. So I guess it speaks about the shape of the LVOT, the absence, on va prendre la valve après, the absence of calcification in the LVOT, and it's likely that the device did slip gradually because of this, you are right, flared configuration of the LVOT with an LVOT that was slightly bigger than the annulus, I guess. So that could have been one of the reasons for that deep implant.
Yes, because it's a major point, because nowadays we try to implant higher, and that may be a problem for these patients because as you can see now, the coronaries are really not far from the waist of the valve, and if you implant the second device, it might be a problem.
Yep, exactly. I think that the case is quite lucky because the evolute is demigrated later, so it would be easier to do the TAVR inter procedure.
The only thing I might do differently is to do the RV pacing instead of using the stiff wire, because he's already have the left bundle, and you're going to expand the evolute further. So there's likelihood of having a conduction disturbance is there. So we usually, when there's a risk, we usually choose RV pacing instead of a stiff wire pacing.
Because the neoskirt plane is below the coronary plane, so I think the coronary obstruction issue is low. So for this 23 SAPIEN 3, we can position the upper frame of the valve just below the coronary artery, so that can get a very perfect result.
That's a very important point of discussion. So where do you, first a question for you guys is, first, do you agree with the choice of the device, a 23 S3, or would you use something else?
Maybe Gilbert, you have the huge experience, so what do you think of the choice?
Didier, great to see this complex case. Yeah, I think 23 would be the right choice, and you saw the in vivo sizing with Vinny Papat's app on the earlier presentation. It's a good size.
Yeah, we use that, yeah.
Yeah, and my question more is that, the valve was already so stenotic. We, at least in our center, like to pre-dilate just enough to help with crossing. Sometimes these can be quite difficult to cross. That's our own personal center preference, although you can see that he crossed quite easily, Didier, there. The other...
there was a bit of friction, so it tells about your experience, but it was a bit of a challenge, I have to say.
Yeah.
Not that easy.
But one thing that we've learned is that the deployment can be quite unpredictable. I think that is the key of this procedure, the short and tall. We see how Didier teaches us how to do this, and any tips and tricks, I think that's going to be the key.
Yep. That's quite an important point.
Okay, so I think we are still learning about these procedures, but we know that it's always a challenge, as you said, Gilbert. So the thing is, first let's image where the top is going to be. We're going to do a contrast.
So Didier, it's the most important part of the procedure. So can you please, for the audience and for us, explain how you position the device? Do you look at the top of the device? Do you look at the distal part of the device? And how would you implant?
Very important point. So let me record without contrast first. And now we can inject the contrast. Perfect. So let's review that, Philippe, for the audience, because it's all about the value of this live transmission, a bit of education and what we can share. We will try to deploy at node 6 to be able, normally you cover the faired leaflets of the evolute, and here we have the focus is not as in a regular tricuspid valve, native valve, the lucent line and then the annulus. The focus is the top of the sapien. So we're going to put the top of the sapien just above node 6 here, because we can take opportunity of having the coronary arteries quite high. So what I'm going to do is, we are at node 6, but we're going to go slightly 1 millimeter higher. So I'm going to slightly push on the wire, okay? And here it's going to, I think it's going to be favorable. So let's inject now. The blood pressure of the patient is fine, so which is good. So I guess we're gonna be ready. Okay. So we're going to pace on the wire at 180, 180, pacing on, to test the accuracy of the pacing. So the pacing is very accurate. So what we're going to do, we're going to inflate very slowly. Melody is going to inflate slowly, very slowly, doucement s'il te plaît. So as you see, it moves a bit, and now you can inflate fully. Okay, perfect. Deflate. And maybe what I like to do is to redo a second inflation. So garde le guide.
So do you routinely do
breathe a bit?
A double tap for these valve-in-valve interventions?
Yeah, we do it because, as you can see, here the blood pressure is recovering. As you can see, I like to do that. Let's record that without any contrast. You can see that we have the first it moved, as Gilbert mentioned, the stability of the device. The second device is sometimes questionable, but here the coronary plane is below the coronary artery, so it's good. There is no issue with that. But what is very important to bounce on your comment, Philippe, is the distance that we have between the evolute and the sapien. So we need to post dilate, and maybe we can add 2 cc's in the balloon. We're going to do that, so Elena is going to do that. Tu peux mettre 2 cc de plus. And we're going to do a second inflation. And I like to do this 2 steps inflation. Tu peux le mettre par là. So 2-step inflation, because it really expands more appropriately the device.
Just to explain to the audience that the distance that we have between the 2 frames is made of the functional new skirt, so having the leaflets of the first valve completely trapped by the second valve. And this is why Didier is going to do a second inflation to be sure, to have a good opportunity and quite long inflation to have a good scaffolding of all this.
Fix. So let's do that now. Tu peux tirer un peu le guide. Perfect. Okay. 180, pressing on. So the blood pressure is really nice.
Did you overfill the balloon?
You can put 2 cc's, full volume.
Okay.
Perfect, full. Okay, deflate, okay, deflate, and then we go pacing off. Thank you. So let the patient recover. Thank you, Elena. And Melody, we're gonna just keep the place.
Yeah, I'm glad you post-dilate, because you have a luxury of implanting more at the waist of the evolute. But if you have to go at like node 4, and we've had anecdotally some cases where it looks good and not post-dilate, and then next day the valve is in the ventricle because of the slippage. So I'm glad you post-dilate, and we do that routinely as well.
So we can naturally see the recovery of the blood pressure. So it's frozen?
Thank you.
Okay, good.
Just for you, just to have a look again at the stent frame expansion. First lesson, it's higher than what was expected, because action of the balloon with the inner structure. So sometimes it's something that has to be integrated. The speed of inflation of the balloon maybe has an impact. So the slower we are, the better it is. And then the 2 steps inflation is really useful, because it's going to help you expand and fight the recoil that we have on the stent frame of the new TAVR platform. So I have to say that for this case, please, when we discussed, we just a final point, we were thinking about Octa Pro 21.5, just to have a device that was going to be shorter, and at the end of the day, maybe a little bit more stable, but this is only theoretical.
Yep.
Please.
So now, so we can see the very good recovery of the blood pressure. So that means the coronary looks great.
Isa?
So any comments on this case?
Yeah, Didier, I think you should tell the audience that you did a perfect fluoroscopic view for implant, which is called, I call it the frame alignment view. It's very important because it's not just any view that no parallax. You actually align the diamonds completely so you can count the nodes to see where the outflow is, inflow, etc. So because it gets very crowded when you have two frames afterwards to be able to figure it out. So I think that's critical part of this procedure as well.
Thank you. So if you guys have a look on the hemodynamics now, so no more gradient, peak-to-peak gradient 0. Very nice diachrotic notch. The heart rate is almost the same. It was 55, 56, it's 60, so it's in the same range. LVED is in the same range, and the aortic diastolic pressure moved from 30 to 64, so which is good. Isa, je veux bien 2 cc d'oxyne, s'il te plaît. We're going to lower the blood pressure because it's very high before we close. So there is nothing more to do here. So what I'm going to do is to withdraw the sentinel, and Elena is going to have a quick look at the baskets to see if there is something that is worth being demonstrated for the audience. Thank you, Melody.
So Didier, thank you very much for the very...
Yeah, please, Kentaro, please.
Thank you so much for the very beautiful demonstration of the TAP in TAP procedure. And sometimes degenerated TAP device is quite difficult to treat because the leaflet is so calcified. And sometimes the second valve behave unexpectedly, but you implant a very good position. So could you please tell us your thought on the antithrombotic therapy after TAP in TAP procedure?
So I have also a question for you, Didier. So was the initial original Evolut valve aligned with the coronary ostia?
Yeah, it was a perfectly aligned.
And do you think that in these cases it may be worth of seeing whether you can reincannulate the coronary artery just in case, the patient comes back with an acute coronary syndromes and you know which catheter you use or whether you can be selective into the coronary arteries?
I think it's something that could be interesting. If the patient was younger, it would be of even major importance if there was a coronary artery disease. But here it's almost 90 years old lady without any coronary issue. But I think it's important to stress the value of a proper commissural alignment at the index procedure, because this is really key to make sure that you can safely perform a redo procedure. And I had from time to time the idea, the perception that maybe if we kind of test the cannulation of the coronary arteries just to make life easier for the people outside our hospitals who are going to treat these patients with coronary artery diseases, it could be of value. But here I don't expect any issue because first the depth. It's in front of the coronary arteries we have very large cells, and second the commissural alignment was perfect, and that was very important. So let's work hard during the index procedure to get a proper commissural alignment. So this is what we have. Final words from you, Guy, based on the angio or anything that you want to discuss?
I think, Didier, one word about Kentaro's comment. How would you treat these patients in terms of antithrombotic treatment? And I have just one comment or question to add. How would you follow your patients?
So follow up. I'm going to do if the renal function is good. We're going to do Tu veux revenir sur nous, sur les visages. We're going to do a follow-up CT scan just to better understand the location of the second device and then the relationship with the coronary arteries and the remaining room within the sinuses. And this is going to answer your point, Kentaro. If we have the feeling that we feel the sinuses and that we disturb the flow within the sinuses, maybe it's not worth it's worth putting the patient under NOAC, oral anticoagulant therapy. It would be NOAC, dual antiplatelet therapy. I don't think there is a need for this lady. It would be NOAC or nothing.
Great. So thank you very much, Didier, for the demonstration.
Yeah, I would like. So let me thank Melo. Thank you, Melo. Thank you, Elena. Thank you, Jess, and thank you, Isa. It was a great demonstration. So we're going to bounce back to room 8, the hybrid room. You're going to see Bastien. So Bastien, is going to put the Safari, and then we're going to move with the Evolu platform. And once again, I'm going to join you, and the team here is going to take care of the patients. So you can put. We're going to put an angel seal on the left side, and I'm joining you guys.
Thank you, Didier.
See you in 2 minutes.
Great job.
So maybe during waiting for the second case. So
I have a question and moderator and other panelists. How do we make a decision pre-dilation in valve-in-valve case?
maybe Gilbert, do you have any comment on?
Yeah, so all our TAV in TAV, especially the first valve, the short valve, we pre-dilate because if you see the CT, they're all underexpanded. And the Vancouver group has shown in paper, even outside on the desktop, you cannot post-dilate two valve. It does not expand the first valve. So the problem, if you don't pre-dilate, the second valve might be more constrained. But of course, you have to do it safely. So we like to get the pre-TAVR CT. So Hassan Jalawi has recommended because sometimes there's a chunk of calcium at the annulus. So if you pre-dilate too aggressively, you can cause annular rupture. So we like to see that to compare. Yep. And we will typically use a non-compliant balloon to help expand a bit more. And then the second valve, whether it's a short valve or tall, it doesn't matter. If it's like this case for Evolut, we pre-dilate just so they can cross more easily because sometimes it can be very difficult, especially the leaflets are fused. You can see on the CT scan they're calcified. But we will post-dilate like what Didier did, and we also post-dilate for the second valve. Yeah.
So in case of the pre-dilatation, which balloon would you choose, VMed or?
No, we like to choose non-compliant balloon because you can get better expansion for the short valve.
True balloon or?
True balloon. But if you have no choice, if you don't have, like for example in Japan, you don't have the non-compliant balloon, you can use semi-compliant as well, kind of like the commander system. So you maybe even be able, let's say for short and short, you would use the same size valve. Typically, you rare to upsize, then you can use the same balloon and just add volume to inflate a bit more. Yeah.
Okay. I think two important points that you mentioned are that when the first valve is a self-expanding valve, you really need to pre-dilate because it's not only opening the leaflet, but it's expanding the first valve, which is the first step before going with the second one. And the other great point is to have a look at the first CT, meaning before the first TAVR, because you can see here the native anatomy. You can see everything that is, your coronary 8 and LVOT and everything that you can see before the first intervention, which is really crucial while thinking about the second one.
Exactly.
Didier, Bastien, we can see you again.
Perfect. We did hear your conversation, so it's the beauty of this.
And the fluoroscopy is completely live.
It's coming back.
There was one comment from Gilbert about the sequence, bouncing to your first comment, Kentaro. Why did we treat the mitral? I understand the fact that we could treat first the aortic and see how the mitral behaves. But at the end of the day, for this patient, the mitral was not functioning anymore with heavily calcified leaflets of the bioprosthesis and a super high gradient. So we said, okay, let's go first for what was potentially the more challenging procedure with transeptal access and so on, TOE guidance, and then we moved. Let's move then afterwards for the aortic case. So that was the first thing. Second, about the potential for fracturing. Can we fracture a trifecta? Would you fracture here, Pasteur?
No, I don't think so. Yeah, I think we can just
stretch it,
but not cracking.
Yeah, so that's potentially something that we're going to do afterwards. If there is a need, we're going to stretch with a 22. The ID is 22. The device is a 26. So let's first go live, Bastien. We're going to align for a commissural alignment, because once again, we have to make sure that we match as much as we can the natural anatomy of the patient, and the commissural alignment was good for this patient. Tu peux enlever ton pied, je vais restaurer. Okay. So we just put the heart marker on the outer curvature, and we're going to follow that during the path through the aortic arch, and just to make sure that it remains on the outer curvature. We may have some difficulty to cross. I can see that. So what we're going to do once again is to go back. I'm going to slightly rotate, and you can start again, Bastien. That's something that we see from time to time. And once again, it's another of the challenges of valve-in-valve cases. You are stuck towards the outer curvature with close to one of the posts. So we're going to try once again, and maybe discuss with you guys what is going to be the plan B. No?
So Didier, for this case, you haven't done the pre-dilatation yet?
No.
Okay.
Exactly. So that's exactly the second step that we're going to do. We're going to pre-dilate with the 22 balloon, and if it doesn't work, we're going to put a Lunderquist long within the left ventricle.
Do you think that the most important explanation for the non-crossing is the valve stenosis, or because of the commissure of the first valve?
I agree with you, Philippe. To me, the main problem here is the angulation, because the valve didn't negotiate the angulation, didn't even with the nose cone touch the valve. So I think it's a problem of angulation more than stenosis.
But the balloon may cover this problem, no? Because the balloon is softer, so you can go in the valve, and then you can...
So you can use it as a body balloon, for example.
How about the use snare?
MPCTF.
Snare,
So a lot of options for you from you guys. That's good. So what we're gonna do is to put a second wire, just a body wire. Donne-moi la CTF MP, s'il te plaît.
Yep.
Or ce que tu as comme CTF, n'importe quoi.
I wonder that in contrast to first case, the second case showed the little lower coronary height, especially in right coronary arteries. So I wonder the coronary protection don't need in this patient.
Here it's we have very large sinuses. The valve to coronary distance is above 6. So the risk of coronary obstruction here for this patient is almost virtual. So, but this is a very, very important comment, and you're right. It has to be part of the discussion that we have for this type of patients here. Okay. So we are waiting. We're going to put a guiding catheter, 7 French, onto the Safari. Within, we're going to put a Lunderquist. What we're going to do first is to try to cross with the help of the support of the Lunderquist, keeping the Safari in place. If it's not successful, with the Safari, we're going to do a buddy balloon. So you know, so it's a kind of combination of everything that you guys just have proposed as options.
Okay, you
so
mean
you see, even the Safari, the multi-purpose is difficult to cross.
You mean you put the 2 wires in the left ventricle?
You may end up needing to snare the valve, looking at this angulation.
Vas-y encore. Yeah, so the 7 French is not crossing. So let's see, donne-nous un 6F. Let's try with a 6 French, guiding catheter, and then we're going to go back to a 5. But interesting case. This is
It might be the post, no? Maybe the wire went into the post or very close to the post.
Yeah, close to the post, because when we did cross, we could put two 5 French catheters. First the Amplatz left one, and second the pigtail within the left ventricle. So I don't think that we are across the leaflets. I think it's more the kind of interaction that we have, and maybe the stenosis at the level of the valve. So I think it's more the stenotic aspect of the valve.
Great.
So let's put the Safari, tu laisses ça, s'il te plaît? Okay, so let's put the Lender crease, Bastien. Thank you. And then we're gonna pre-dilate, because it's gonna be difficult to cross.
I like this idea. I haven't tried it.
And Didier, I think it is important to tell the audience that you don't want to cross through the sapien, because you have a sapien in the mitral position already. So when you initially cross, you want to make sure your wire is free. So fluoroscopically, you want to make sure.
But it's also a very important point, Gilbert. But we used to use snare for the Pro Plus or Pro device. But nowadays we have FX. So it's quite rare to use snare. But however, if everything doesn't work, maybe we can think about the snaring.
Yeah, snaring would be the last option.
Yep.
I have to say. Okay, so let's try to cross like that. So we have the Lender quiz and the buddy wire. So let's see what we have.
Please go ahead.
Okay, thank you.
So you put it over the Lender quiz?
Yeah, it's exactly over the Lender quiz. The stiffer wire. So we are in first the external curvature, outer curvature. Let's try to match that. It's good. And then, okay, Bastien, let us know if it works. It works.
Great.
Continue. Okay.
Congratulations.
So very nice demonstration of the tips and technique to cross with the second.
Yeah, we need to have a very great toolbox. So that's why I like to discuss with all of you guys, because it's a lot of energy and ideas. So here the thing is to withdraw the Safari. Here it is. So Chloe is gonna take the Safari, and then we're gonna bring back the Evolute, Bastien target, and then we're gonna move forward. So I guess we can advance this. Okay, so let's record first Cécile and Anjou. Okay, Ciné, Bastien. Perfect. Yeah. So we can see that, so let's review that, Bastien, sorry. Yeah. Let's take 1 minute to review. We can see the sinuses, and it's a kind of slightly, Gilbert, if you agree, supraannular position of the trifecta. So if we put the dots of the Evolute just at the level of the annulus, it could work.
So did you put some shape on the Lender quiz or not?
Yeah. I did a curve.
Okay.
But it's true that you have the ability to use the double curve Lender quiz, which is another wire.
Appreciate it.
Okay, let's recross. Okay, perfect. So let's focus now. We're going to zoom in just for you guys to better follow what we're doing. So the idea is first, in terms of commissural alignment, it's good. So we're going to go slightly, very gently, and go at 0. Yeah, higher. I guess you can go slightly higher.
The projection you selected is really nice, because we can clearly see the level of the trifecta, but also the relationship with the mitral sapien. Would you comment on that?
Yeah, it's just to make sure that we have a nice commissural, the nice cusp overlap projection to do commissural alignment. So here we're going to, so we make sure that here you can see that 2 of the dots, you can record that, Bastien, maybe? Thank you. So 2 of the dots of the Evolute are overlapping, and 1 of the dots is facing the commissural between the left and the right. So in terms of commissural alignment, we're perfect. So we are reaching node 2, so we're going to pace at 100 and let's do it 150, because it's a quite dynamic environment here. Thank you. Okay. So let's, so it's not expanding. So what we're going to do, we're going to push on it, Bastien, very strongly. We're going to use the Kentaro technique, the Japanese technique, expand it a little bit lower, un petit peu pousser dessus. And then we're going to then bring it back.
Distal opening.
Perfect. Yeah. Distal opening technique, you're right. So Bastien, you can go back at target. Perfect, and we can push on it. Perfect. So let's go back at 40, Cécile. Okay, let's record that. And then we're gonna do an angio. Je vais ramener la pictelle au-dessus. And let's do an angio. Voilà, c'est bon. Un peu plus bas. Thank you. Okay, so let's do an angio here, and then we're going to discuss the depth, guys. But I guess that we will need to stretch the device. 25, s'il te plaît. We will need to stretch the device because it looks really constrained within the valve. Okay, let's repeat the angio, Bastien.
Do the same thing again.
Okay, nice. So what do you think about the position, guy?
Maybe Gilbert, do you like this position?
Yeah, I think since it's already under-expanded, you need to post-dilate. I would keep this depth because if you implant too high, you will not be able to do that. This is a perfect depth in my mind.
Exactly. That was our comment.
Everyone agrees. That's good.
Okay,
Great.
so let's. We're gonna very gently go to the LAO projection, just to confirm that we are well located, just below in the left coronary side. So it's good. So let's go back to our projection, Bastien. Sorry, and we're gonna deploy the device.
Left.
Okay. Okay, so you can just withdraw slightly the wire, and you can push on the device. And I'm going to go very slowly. I guess the speed of expansion of the outflow. Is very important, and I can feel that you are pushing, and it's good just to make sure that we are stable. Perfect. So it was stable in terms of depth. So let me withdraw the nose cone, keeping the lambda twist in place. We're going to bring back the 14th French sheath, and then do the post-heel immediately.
What balloon will you use to do the post-dilation, Didier?
So it's going to be a 22 by 40. Yeah. So just a one-to-one relationship with the ID of the failed device. So thank you, Chloe.
Very beautiful demonstration, deployment. Now the depth looks really good.
Yeah.
Yeah. So about you see we do the when we learn something, we do the exchanges with you. What we're going to do maybe is to bring back the safari. Let's put the pigtail, Chloe, and then we're going to put the safari. And that technique of distal opening comes from you guys in Tokyo. So I use it very regularly when it's difficult.
Thank you so much. We learn each other, always.
So due to the pacing during the deployment of the valve.
Yeah, we did the pacing. Once you reach node 2, you start 0 inflow, first row of connector node 1, second row of connector node 2, and then you start pacing because it's going to flare. So, and we did pace at 150. Just to get something that was more stable, because with valve-in-valve stability is an issue. No, tu peux flusher. Merci. Okay, so we have the safari in place. Let's do the post-deal, do a bit of hemodynamics, and then we'll do the final angio, and I guess it will be time, guys. We're going to be on time, so which is good. Thank you for the mental support.
You have time.
Despite the
Take your time.
challenges.
Yeah. Just one word for the post-deal. Would your intention is to remodel the trifecta or just to open the evolute?
Yeah, it's more to stretch remodeling. So it's going to be a regular balloon, semi-compliant. We can fracture, in fact, trifecta, but you have to use very big balloons at very super high atmospheres. So it can be a kind of dangerous for the anatomy for the leaflets. So maybe, Bastien, we can go, a little bit back. Thank you. 180 is Cécile. So let's wait for the stability. Yeah, it's coming. So it's stable. We can film, Bastien. And you can push on the balloon. Perfect. Push on the balloon. And pacing off. Perfect.
Much better.
Yeah.
Very good expansion.
Yeah, it's very important to follow all the steps. Because achieving good outcomes, it's quite demanding. It's not only about deploying the device, but we have to analyze everything that we discussed with you guys, and it's super important. Yeah, so we're going to do the recording, Bastien. We're going to do the hemodynamic assessment, and then kind of wrap up. The depth is good. The commissural alignment is super nice, so it's perfect. Yeah. So let's see now the hemodynamics. Still a kind of challenge even to cross with the pigtail. So I guess the tortuosities of the patient may also play a role. Et on va mettre celui-là sur le 14F.
And no interference with sapien.
Yeah.
No, not at all.
Even when you did the post-deal, we could see that we were far from the sapien, which is really great.
Exactly. You have the eyes everywhere, Philippe.
And also when you do the post-dilatation, you apply some force to prevent the migration of the valve. It's very important.
Exactly. Very important, as you said. So here is the hemodynamics. So, Bastien, no gradient?
Yeah, there is no more gradient. Everything remains stable.
Yeah, the heart rate, but he has a pacemaker, so it's good. And you see the very large difference between the diastolic aortic pressure and the left ventricular and diastolic pressure, so we don't expect any regurgitation. So, okay, let's do the final ensure. I'm going to zoom out just to see the ascending aorta because we did work a bit on this at this level. So let me withdraw just a pigtail for you. And if you can put the pigtail just in the outflow, it's going to be great. Et 40 à 15. Un peu de scopie. Let me align just the trifecta and the device, and I guess it's going to be good like that. Okay, so let's record. Thank you. Perfect. Nice.
Beautiful.
Nice. Okay, guys. So this is what we have. So these were very challenging cases, and on a personal note, I'd like to thank the team because it was really super important to be surrounded by professionals like you guys. So thank you for supporting these cases for our patients because the outcomes are very good. So maybe the floor is yours if you want to wrap up.
Thank you, Didier.
Offline the grind.
Thank you, Didier, and the team in Toulouse. You did a great job as always, despite technical issues at the beginning of the transmission. But again, we had two very, very nice demonstrations of, I would say, complex TAVR. And the first one was a TAV in TAV, and the second one a TAV in SAV, and very, very good key learnings from you, Didier, tips, and really a great demonstration. So I think, Kentaro, we can now say thank you and see you soon, and thank all the panel for the great discussion. Thank you very much.
Thank you. Thank you for having us and allowing us to be part of the meeting. So all the best for the rest of the meeting, and thank you for the support for this case. Thank you, guys.
Thank you so much.